So just to give you a brief sort of background to Bomedemstat. So basically, why was that trial designed and why is that trial so useful? I think the first thing is that LSD1, all right, or the lysine-specific demethylase 1 actually is associated, all right, with sustaining the malignant stem cell activity. So it's naturally a target for us in the management of myelomalignancies. And obviously, as we know about myelofibrosis, so a lot of the clinical manifestations and the disease manifestations are actually secondary to the malignant megakaryocytes and the clonal hematopoiesis involved. So inhibiting this particular pathway is a certain sort of a target for us. So that's the reason this particular trial was designed based on the preliminary work. So basically, it's a once daily dosing of treatment. And so far, in fact, in all other evaluation has been evaluated in more than 170 myeloid patients with myelomalignancies with no sort of safety signals observed. And we'll update you on the phase 2 results. In fact, some of the results were previously presented at EHA. All right. So basically, it's an ongoing phase 1/2 global study. And the primary endpoints were the safety and tolerability and the pharmacokinetics and the spleen volume reduction. We had important secondary endpoints that comprised symptom burden reductions, changes in cytokine profiles and the mutant allele frequencies, and also changes in the marrow fibrosis. So the key eligibility were primary or secondary myelofibrosis and patients with resistance or refractoriness, right, to the existing available therapies. And those were mainly JAK2 inhibitors. So in other words, most of these patients failed the conventional JAK2 inhibitors, mostly ruxolitinib. Right? And obviously, we ensured these patients had a good performance status of 2 or less, and without any evidence of disease acceleration, and baseline splenomegaly was allowed. So what we did, we treated these patients with a daily dosing. We started off at a 0.5 mg per kilogram dosing, and then it's a once daily dosing, and we usually adjust the treatment every 2 to 4 weeks until a target platelet of around 50 to 75, right, as a therapeutic target for us to achieve the benefits of this particular agent. So this was the actual design of phase 2. So it's a single arm. So basically, as far as the results that we'll be presenting, we have actually completed the enrollment of a total of 89 patients. All right. So I'll be presenting on the evaluable patients as well. So 89 patients were enrolled with a median age of 68, mostly men, 52%, and mostly patients with primary myelofibrosis, 46% patients with primary myelofibrosis. The rest were either post-ETMF or post-PVMF. And most patients were actually IPSS, the International Prognostic Scoring System, intermediate 2 or high risk. In fact, 39% for intermediate 2 and 53% for high IPSS. And most of these patients were treated with ruxolitinib. 74% of these patients were treated with ruxolitinib, and a median of 2 prior lines of therapy. And most were JAK2 mutated, 64%, as you would expect, followed by calreticulin mutations and MPL mutations. And of note, 38% of this treatment population actually harbored the high molecular risk mutations like AXXL1 especially, and also the IDH1, IDH2, EZH2, ZSF2, and U2AF1. So this is the actual background, and as far as the safety and tolerability is concerned, the commonest non-hematologic toxicity was dysgeusia, all right? But then it was mostly tolerable. All other hematologic toxicity was thrombocytopenia, but that was somewhat expected because we aimed a lower target platelet count. So, but then there were no significant safety signals observed or deaths related to treatment observed in these patients. And I'd like to go over with some of the important primary endpoints. As far as a total symptom score at 24 weeks was concerned, 74% of patients, evaluable patients, had reduction in total symptom score. And 26% had a 50% or more reduction in total symptom score. So these were patients who were refractory to ruxolitinib mostly and achieved a further reduction in the symptom burden. So that's quite important. And the spleen size reduction also occurred in 75% of the evaluable patients. An important thing I'd like to highlight about this study was that there were hemoglobin improvements in patients. So in patients who were transfusion independent, the hemoglobin remained stable, even increased in more than 40% for about 1 gram per deciliter over time. And there were a number of patients who actually achieved transfusion independence too. And another important secondary endpoint was the reduction in the mutant allele frequency of the important driver genes. Overall, most genes had reduction in their mutant allele frequencies, all right? And that's an important thing. And the other thing is that AXXL1, which is one of the high molecular risk mutations, in fact, 45% of these patients harboring this particular mutations had reduction in the mutant allele frequency. This actually points towards a disease-modifying effect of this particular agent. All right. So in conclusion, it's safe as a monotherapy, and it also showed an important achievement in terms of the symptom reduction and also evidence of disease modifications. So obviously, we need to wait for longer-term results of this particular study to see if these effects were sustained. So I think this is a sort of a sum up of this particular study that I will be presenting in ADASH.